Now, submandibular region extends from the submandibular fossa of the body of the mandible to the hyoid bone. Now, submandibular and sublingual glands, suprahyoid muscles, extrinsic muscles of the tongue like hyoglossus, genioglossus and styloglossus. Lingual and hypoglossal nerves, submandibular region, and lingual and part of the facial arteries. Now, you can see the structure. This is submandibular gland, the deeper part, and see the muscles in the submandibular region. Now, this is the styloid process and styloglossus muscle. Styloid process, from there the muscle attachment is here up to the tongue, and stylopharyngeus nerve, a muscle, the lingual nerve, submandibular duct. This is submandibular duct, profunda lingual artery, and the submandibular ganglion is here. Submandibular gland, deep part. This is the deep part. This is the superficial part. The middle constrictor muscle, hypoglossal nerve, the facial artery of the cervical part, and the lingual artery, the first part. Now the submandibular gland, superficial part, mylohyoid muscle. This is the hyoid bone, and this is the mylohyoid muscle. The sublingual gland is here. The digastric muscle, the anterior belly. When you read the anatomy of the mandible, the two protrusions are there, and now introduction. Mixed gland lies in the digastric triangle and partly lodged in the submandibular fossa of the mandible up to mylohyoid line opposite molar and premolar teeth. The gland consists of large superficial part and small deep part. Both parts continuous around the posterior border of the mylohyoid. Now you see the superficial part of the gland, the submandibular gland, investing deep cervical fascia. Now the fascia just encircles, it bifurcates and gets attached. Now mylohyoid vessels and nerve, the mylohyoid muscles. This is the facial artery, facial vein, platysma muscle, skin. Parts superficial and deep. Superficial has two ends, anterior end and the posterior end. Three surfaces, inferior, lateral and medial. Inferior, lateral and medial. The anterior end extends up to the anterior belly of the digastric. Digastric muscle, the anterior end extends up to the anterior belly of the digastric muscle. The posterior extends up to the stylomandibular ligament, which separates submandibular and parotid gland. Now when you see the deep dissection of the neck, and also you will see a prominent, the stylomandibular ligament, which separates the submandibular and the parotid gland. The parotid gland will be superficial, submandibular gland will be deeper to it. Now, investing layer of deep cervical fascia splits into two layers, covers the inferior and medial surfaces of the gland. It bifurcates and covers. Now, the inferior surface, the skin, superficial fascia, platysma, deep cervical fascia, common facial vein, cervical branches of the facial nerve under cover of the platysma, and submandibular lymph nodes beneath the deep fascia. Now, these are the structures and the platysma muscle. Whenever you do a dissection, and you have to be very careful of these structures. Now, lateral surface. Now, submandibular fossa of the mandible, medial pterygoid muscle, and facial artery loop between bone and gland. Now, you leave the skull, the pterygoid plates over the medial pterygoid muscle and the lateral pterygoid muscle. It's attached to the pterygoid plate of the skull bone. And facial artery loops between the bone and the gland. Medial surface, three parts: the anterior part, the posterior part, and the intermediate part. The anterior part rests of the myeloid separated by myeloid vessels and nerves, which I told you, I showed you in the previous slide. The rest of the myeloid separated by the myeloid vessels and nerves, submental branch of the facial artery. Now, the posterior part is related to styloglossous, stylopharyngeus, glossopharyngeal nerve, posterior belly of digastric, the middle constrictor muscles of the pharynx, hypoglossal nerve, and first part of the lingual artery. The posterior part is related to the styloglossous muscle, the stylopharyngeus, and the glossopharyngeal nerve, posterior belly of digastric, middle constrictor muscles of the pharynx, hypoglossal nerve, first part of lingual artery. Now the intermediate part rests on the hyoglossus muscle, hyoid cord to the tongue. That is the hyoglossus muscle. The lingual nerve you can definitely identify. Submandibular ganglion, hypoglossal nerve, pair of the vein corresponding to hypoglossal nerve, intermediate tendon of the digastric. Now the deep part of the gland extends forward in that interval between the myeloid and the hyoglossus up to the posterior end of the sublingual salivary gland. Deep part extends forward in interval between myeloid and hyoglossus up to the posterior end of the sublingual salivary gland. Relations of the deep part: laterally myeloid, medially hyoglossus, above lingual nerve and submandibular ganglion, below hypoglossal nerve and accompanied by veins. Myeloid is laterally placed, and hyoglossus, the muscles of the tongue, hyoglossus, that extends on the hyoid bone. Submandibular duct begins from the middle of the deep surface of the superficial part of the gland behind posterior border of hyoid, passes upwards and backwards and then runs forward, upwards to the deep part of the gland between myeloid and hyoglossus muscle. You will see it in the deep dissections of the neck. Then runs between sublingual gland and genioglossus and opens in the floor of the mouth and sublingual papilla on each side of the frenulum linguae. You see, we have shown you the mandible, and You raise your tongue, you can see the ducts opening. Now, the frenulum linguae at times it shortens, and that is known as tongue tie. So, an operation is done. Nowadays, the dentists, the dental surgeons, they are doing this operation. Previously, dental surgeons used to do. Wharton's duct is intimately related to the lingual nerve. At first, nerve lies above the duct, then crosses it lateral side and ascends medially, winding around the lower border of the duct. Deep structures of the submandibular gland, the anterior removal of the superficial part of the gland and mylohyoid muscles and breaking body of the mandible. You see the hyoglossus muscle, genioglossus, styloglossus, deep part of the submandibular and sublingual gland, stylopharyngeus, middle constrictor and part of the glossopharyngeal nerve. Now, the mylohyoid. Now, hyoglossus, the hyoid bone and the tongue, genioglossus, styloglossus, deep part of the submandibular and sublingual gland and stylopharyngeus, middle constrictor, part of the glossopharyngeal nerve. Thyroid, parotid, এটা তোমাদের অর্গানে থাকবে এবং what I want to say is that it's be a long question or just on the duct or the parotid gland itself, and you will be given in the viscera table of the head neck. Thyroid is very commonly given, parotid is given. So you must ever submandibular gland you have to be reading everything. That is the big question. You have to read, or they will talk on parotid and suddenly they may switch over to submandibular gland, the other parts. If you answer very well, then they will definitely question you to give you honors. Okay? Now, parotid gland is the largest salivary gland, situated behind the ramus of the mandible, the retromandibular fossa of parotid bed. In the retromandibular fossa of the parotid bed, you can see and parotid bed is pyramidal in shape. Here is the gland. You can see the sternocleidomastoid muscle, the facial nerve is here, the parotid gland itself, this is the parotid duct, this is the zygomatic arch, external acoustic meatus and mastoid process. Over here the digastric muscle, the masseter muscle, and this is the parotid. Now, boundaries of the parotid bed. Anteriorly posterior border of the ramus of the mandible. The mandible is there. The posterior ramus, you have read in osteology. The posterior ramus, how the posterior border of the anteriorly posterior border of the ramus of the mandible. Posteriorly mastoid process, superiorly extends to the external aquatic meatus. Here's the external aquatic meatus, and posterior part of the temporomandibular joint. This is the temporomandibular joint. This portion. So you can see the boundaries of the parotid bed, and medially styloid process. Now muscles lining the parotid bed. Now ramus of the mandible, masseter and the medial pterygoid. Mastoid process, posterior belly of the digastric, styloid process, styloglossus, stylopharyngeus and stylohyoid. These are the muscles here, three muscles rising. Extent of the parotid gland, above, just beneath the external auditory meatus. Just in the external auditory meatus, below upper part of the carotid triangle. Medially, styloid process above and neck of the mandible below. Posteriorly overlaps, anteriorly extends over the masseter. Accessory parotid gland. Anterior part of the gland may get detached from the rest of the gland. Lies between zygomatic arch above and parotid duct below. Accessory gland, there might be the pyramidal shaped gland. There will be another parotid tissue as described here. Anterior part of the gland may get detached from the rest of the gland. Lies between zygomatic arch above and parotid duct below. Now coverings of the parotid gland, inner true capsule and outer false capsule, inner true capsule and false capsule, true capsule condensation of the fibrous stroma of the gland, false capsule splitting of investing layer of deep cervical fascia. I think when deep cervical fascia was taught to you, then the false capsule splitting here, this is the investing layer of the deep cervical fascia. That's why parotid swelling, any pathology related to the parotid gland, it is very painful because it cannot stretch. You have an abscess over here, it goes and big. But in parotid gland, it is been encircled by the deep cervical fascia which splits and covers the gland. Now false capsule of the parotid gland, superficial fascia and deep lamella. Superficial lamella blends with the epimysium of the masseter parotidomasseteric fascia. And parotidomasseteric fascia is attached above to the zygomatic arch. Here's the zygomatic arch. And deep lamella thickened to form the stylomandibular ligament. This is the stylomandibular ligament. And stylomandibular ligament extends from the tip of the styloid process to the angle of the mandible. Here. Up to the angle of the mandible here. Now, presenting parts of the parotid gland is, it has an apex, base. Here it's like a pyramid. Now, the medial border is here, the posterior border is here, and anterior border is here. Now, the superficial surface is the anteromedial surface, is the posteromedial surface. Anterior, posterior and medial borders. Apex of the parotid gland. Now, this is the apex. This is the parotid duct. And now why you have to hold it. The parotid gland is given in your to identify, and Now you, with the apex pointing upwards and the duct anteriorly. ধরো এটা উল্টে দিয়ে তুমি যদি দেখো তো ডাকটা এদিকে চলে আসবে পেছন দিকে। নো, it has to be anterior. So left side, right side. Structures passing through the apex. This is important. Cervical branch of the facial nerve, anterior division of the retromandibular vein, and posterior division of the retromandibular vein. Now, base of the parotid gland, concave in lining, related to external aquatic meatus. Here's the external aquatic meatus, and posterior part of temporomandibular joint. Structures passing through the base, a temporal branch of the facial nerve, auriculotemporal nerve, superficial temporal vessels. Now, superficial surface of the parotid gland, skin, superficial fascia, superficial group of parotid lymph nodes, superficial lamella of false capsule. From external to interior, you go in skin, superficial fascia, superficial group of parotid lymph nodes, few lymph nodes are there. So, and superficial lamella of the capsule. Now, anteromedial surface of the parotid gland, related to posterior border of ramus of mandible, related to masseter and medial pterygoid muscle, structures related to branches of the facial nerve and the maxillary artery. Now, posterior medial surface of the parotid gland is related to the mastoid and styloid process of the temporal bone, related to the posterior belly of digastric, related to muscles of styloid apparatus. Facial nerve enters parotid gland by piercing this surface. Now, posterior border of the parotid gland separates superficial and posteromedial surface. Structures related to the posterior auricular branch of facial nerve, posterior auricular vessels. Anterior border of the parotid gland separates superficial and anteromedial surface. Structures related, zygomatic, upper and lower buccal and marginal mandibular branches of the facial nerve. Transverse facial vessels, the parotid duct, accessory parotid gland and duct, if present. Now, structures passing through the parotid gland, facial nerve and its branches, retromandibular vein, external carotid artery. Now, facial nerve. Actually, there might be a short note on facial nerve. Then, its important component of facial nerve is passing through the parotid gland. It emerges from the stylomastoid foramen, pierces the posteromedial surface, runs forward as the most superficial structure, divides into temporofacial and cervicofacial trunk. 5 terminal branches emerges from the anterior border. 5 branches like this. And branching pattern known as pes and serinius. Facial nerve. Now, surgical importance of the facial nerve branches. Now, branches of the facial nerve divide into parotid gland into superficial and deep lobes. The branches are sandwiched between the 2 lobes. This orientation helps the surgeon to remove a parotid tumor or leaving the nerves intact. Now, you have any patient comes to you with a parotid swelling, you immediately do an ultrasound and see, and also do a fine needle aspiration cytology to detect if it is malignancy or not, or simple parotid adenoma, non-malignant. You have to distinguish between them, and accordingly, if it is a adenoma, then you send it to an ENT surgeon. He will remove the parotid adenoma, and if it is a malignancy in your FNAC report, then it will be accordingly, you discuss with the oncologist, and he will guide. It will be chemotherapy followed by radiation, or excision followed by chemotherapy radiation. So it is very important, don't take it lightly, of any swelling in the parotid region. Of course, sometimes if, the lymph nodes might be inflamed, but lymph nodes will be discrete. It can be, you can feel it, but the adenoma, you can feel it also, and also see it is a part of the gland. Even if it's a malignant tumor, it is part of the gland. See, this is the branch of the facial nerve. This is the isthmus, this is the superficial part, this is the deep part. Now in between, you have to dissect out, not injuring not causing injury to the facial nerve, because the facial nerve supplies, it might be, if you tamper it, then there will be some facial palsy. Now, retromandibular vein occupies the intermediate zone formed by the union of the superficial temporal and maxillary vein. This is the retromandibular vein. Temporal and maxillary veins divides and emerges as an anterior and posterior division. Anterior and posterior division. Now, external carotid artery occupies the deep zone, divides into terminal branches. Maxillary artery lies deep to the anteromedial surface. Superficial temporal artery emerges from the base. Transverse facial artery emerges from the anterior border. This is a sense duct or parotid duct, short node. Now length 5 centimeters, formed within the gland by union of two vertical ducts. Emerges from the anterior border of the gland. So when you are asked to hold the parotid gland in anatomical position, your duct should be anteriorly placed. Now, pores of the duct. This is also the parotid duct. Describe the parotid duct. A short note, whatever the number is. Now, the duct passes forward on the masseter muscle, lies between upper and lower buccal nerve. At the anterior border of the muscle, abruptly turns medially. Pierces the buccopharyngeal fascia and buccinator muscle. This is the buccinator muscle and the buccopharyngeal fascia. Passes between the buccinator and the mucous membrane of the cheek. Opens opposite the crown of the upper second molar tooth. Blood supply of the parotid gland. Arterial supply derived from branches of the external carotid. Arterial supply derived from the external carotid artery. Veins drain into the tributaries of the external jugular vein. Nerve supply of the parotid gland. Secretomotor supply from parasympathetic and sympathetic. Secretomotor supply from the parasympathetic and sympathetic. Parasympathetic stimulation, watery secretion. Sympathetic stimulation, mucus-rich sticky secretion. A parasympathetic nerve supply, preganglionic fibers, inferior salivatory nucleus of the medulla. When you read the brain, you will see the inferior salivatory nucleus of the medulla. Fibers pass through the tympanic branch of the cranial nerve, reach tympanic plexus, relay to the otic ganglion. Posterior ganglion fiber reach the gland via auriculotemporal nerve. Now, sympathetic supply, preganglionic fibers from sympathetic trunk relay to superior cervical ganglion. Postganglionic fibers reach the gland around the external carotid artery. Freday's syndrome. Short note. Now, penetrating wound of parotid gland damages auriculotemporal and great auricular nerves. During healing, secretomotor fibers of anterior nerves, the nerve joints, distal and ear nerve through nerve fibers reaches the sweat glands of the facial gland. During eating, perspiration occurs on the skin covering the parotid, and stimulus intended for salivary secretion produces sweat secretion.
We have again come back to our physiology class. Is it the first physiology class after the holidays? Good, I am lucky. You were unlucky. Somebody is lucky, some other persons will be unlucky. Because today it is scheduled class of Soham, but for some reason he has taken leave, so I have been sent. So let us, instead of going to a new topic, let us discuss something relevant. Like the exam is nearby. So how our theory questions are. There will be two 15 marks question. This question is not a single question, but it is a split question. Usually these questions, the 15 marks questions, start with a clinical scenario. It may not be clinical. In physiology, it may be something else. Like it may start from sports physiology, it may start from our everyday life, etc. But usually some scenario is given at the beginning of the question, and then the question starts. Like the last, I remember one question was, an old man aged, say 62 years, is brought to the emergency. He is having that right-sided paralysis, but along with loss of speech, etc., etc. Then the question is, what is aphasia? What do you mean by upper motor neuron? What are the different types of aphasia? What is upper motor? What is its difference from lower motor neuron paralysis? Etc., etc. So, question starts with a clinical scenario. So, don't get confused. Read it clearly, attentively, and then you will find that it makes sense. The scenario makes sense. Then after that we have three questions, 7 marks in each paper. First paper and second paper. The first paper consists of what is taught in the first term: general physiology, blood, nerve muscle physiology, digestive system, cardiovascular system, respiratory system, and what else? Anything? Right here. General physiology, and second paper consists of excretory system, endocrine system, reproductive system. I think endocrine is over, huh? Endocrine is over, I think. Is it? Then nervous system, and then spatial senses. These 5, these 6. Anything I left? Anything I left? What about good students? All are good students. Anything I left? You want to say something? No? Okay. Now each paper will have 2 questions, long questions, 15 marks each into 2. Then 7 marks, 3 questions, short answer questions. Then there will be explain why. 5 questions into 4 marks. I can't do. One note. Two short notes. I think there are three 30, 30, একুশে I there are 3 into 8 questions. Must be 2. MCQ 10. I think this makes 100. 8 marks, 2 questions. 7 marks, 2 questions. Explain why. 4 questions. Or 5 questions, each 4 marks. Short notes, 2 questions, each 5 marks. And MCQ, 10 questions, each 1 mark. This makes 100. And for the last few years I have been finding that out of the 2 short notes, 1 short note is coming not from regular physiology, but from 8com. You know what is 8com? You know, I think. Community medicine people teach you. You know what is 8com? Anybody? What is AETCOM? Yes. This is 5 marks. If you can't answer, 95. And out of 5 usually we give 3 marks to each without very much reading the answer. What is 8com? Yes, good. Attitude, ethics, and T. Com is communication. Yes? Oh, I can go this way. I can reach you quickly. What is T of 8com? He said 8com, A for attitude, E for ethics, T for yes. ET for ethics. And C, communication. The whole com is communication. The term doctor. So what is doctor responsibility, is duties? Everybody started meditation, writing whatever comes to his meditating mind. That is what I found. And all of them I gave 3 out of 5. But there will be another short note that will be from physiology. That you have to write correctly from physiology books. So 15 questions, long question. So what I will do, I will find out different questions, and I have a plan to answer I have a plan, and that is answering different types of questions on neurophysiology over this WhatsApp, through the WhatsApp group. That will be my answers, and you write your answers. Many of them will be better than my answers. See, if you feel they are better than my answers, please send me them. Then I will improve my answers. Let us start with, say, short note. So one short note. At the beginning of this nervous system classes, I remember I taught you about, I should not be proud to say that I taught you, but anyway, I discussed the topic Bell-Magendie's law in the class, at the beginning of the neurology classes. Now, suppose this comes as a short note. What will you write? Let us discuss. E-examiners who said yes, the minimum they have written, so they should get at least pass marks 50%. So it depends, but you will be suitably rewarded. It is Charles Bell and Francois Magendie. Magendie is from France, from the name itself you can understand. So Charles Bell and Francois Magendie. Francois Magendie, they are the first persons who stated this law. What they said? The ventral roots of the spinal cord carry the efferent or motor fibers, and the dorsal roots of the spinal cord carry the afferent or sensory nerve fibers. But they did not do it simultaneously. They did not publish papers simultaneously, but they did it separately. So later there was huge controversy. Who actually discovered this law? It was law discovery because it was not invented. It was there for thousands and thousands of years since human beings came into existence, and it was discovered by Bell and Magendie both. And Francois Magendie published paper in French language, Charles Bell published paper in English language. Anyway, and later it was known that they are stating the same thing. So there was some controversy who actually discovered it, and later on the law was told as Bell-Magendie's law. The names of both were included. It is in 1822 that the papers first came into existence. But Bell did one more thing. He expressed his debt. They did not prove it, but they stated it. These persons were very talented, great persons, fathers of anatomy or the whole medical science, you can say, like Galen. So then there is Erasistratus. You know Galen is a famous person, father of anatomy. Once we are coming in the same car from Calcutta to Bolpur with Swapon sir, and by mistake I uttered the name of Galen in front of he. Then he said, the Galen's original book I am having with me, with all the illustrations. And oh, is it still available? He said, it is not easily available, but somehow or other, from various sources, after searching a lot, I found the book of Galen, and it is still with me. So, Galen is a very famous person. If you want to know further about Galen and his works, you can talk with Swapon sir. So my responsibility, I don't have the book and I have not read much about him. Erasistratus is another. Then Aretius. Aretius is another person. And Heterophilus. Heterophilus. And these are so great persons, somehow or other, they understood that all motor fibers are coming through the ventral root and sensory fibers are going towards the spinal cord through the dorsal root. But they did not have electrophysiology experiments. But it is Bell and Magendie on two different sides of Europe. They proved with their initial electrophysiology experiments, and in 1822 published papers separately to state the Bell-Magendie's law, this time clearly, without hesitation, and only after laboratory proof by using neurophysiological, electrophysiological experiments. Next, later on, some people found that in the anterior root, some afferent fibers are there. So they said they must be axons. They must be axons. AXON, not AC. Whenever I try to dictate in front of the mobile phone, when I write down your questions, answers, etc. in WhatsApp, whenever I say action, the spelling comes ACTION and never AXON. But in physiology, this is AXON and not ACTION. So they thought it is an action. So Bell-Magendie's law is not totally right, they said. But later another scientist and with some of his colleagues, Rising and others, they were a very rising fellows those times, and using further electrophysiological experiments, particularly neurochemistry, neurochemical techniques. They used neurochemical techniques, and with those techniques they found if they injected something into those afferent nerves, the material comes back through the same nerve. So it is something like a loop. It is not afferent fibers going into the spinal cord. These fibers, which were detected by somebody as afferent fibers in the ventral root, actually they come back. So this is a very good neurochemical experiment. There are substances like, say, horseradish peroxidase. Horseradish peroxidase is a kind of stain, and this can be detected by microscope, good microscope. With that they found that the motor fiber, the anterior fibers or ventral fibers, that means the ventral nerve root, the fibers which were thought to be afferent are not afferent. So these things you can write in your short notes. Rising experiments of Rising et al. It was much later, 1974 or so. I don't remember the year, but it is something like that. So that is Bell-Magendie's law. Well, Bell-Magendie started this. There was again some hue and cry. Why this hue and cry? That people said they worked on living animals. So they did some anti-ethical. They killed animals. They did these experiments on animals, means by dissection they found. But then they said, no, we did it on dead bodies. But the dead bodies were fresh. And when we did it, still the bodies were neurologically active. That means the nerves were able to carry electrical impulses. So it was that time that the ethical committee in the Royal Society, they gave the ethics, how much you can work on living bodies, whether it is human or animals, and they framed some laws. So this was the beginning of those laws, and so people said that this is the new law. You have to follow this whenever you are doing any dissection or whenever you are doing any. Now next is saltatory conduction. This is also a In neurophysiology, this is also another short note. You want to go? Sure. Anybody want to go anywhere? Saltatory, it is, I believe, this is all my fault or deficiency. If students don't want to stay in the class and they want to go outside, so if students keep going outside, I have to leave this job. Either I have to leave myself or I will be forced to leave the job. Anyway, that's a different thing. I remember I was in a college, in a private medical college, a teacher. One day I found that my students are not listening to me. They appeared to be very much not interested in the class. There also I was teaching neurophysiology only. Probably it was cerebellum. Anyway, I came out of the class when the class was over and I felt I was not feeling well, means I was having some problem with my eyes. And one of my PG students, he was already a diploma holder in ophthalmology. So I said, I have some problem with my eyes. Please check my eyes. Tell me what has happened. Any conjunctivitis? He said, it was a lady. She said, no, sir, it is not conjunctivitis. You are having a subconjunctival hemorrhage. This usually happens due to some drugs. Are you taking? I said, no, I am not taking any drugs. Or hypertension. I never have any hypertension. My blood pressure is always systolic blood pressure between 110 and 20 and diastolic 70 and 80. Then he said, anyway, so other students came and examined my blood pressure. It was quite high. I said, this is the first time I am finding my blood pressure is high. So I took leave for a few days, got my eyes examined in Disha in Calcutta and got some opinions from a cardiologist why the hypertension. So when I came back, there was a big hue and cry in the college because the students were not attentive. So sir was very sick. It was true that I was very sick for that time. So things happen. I can't blame anybody. For anything happening in my class, I always blame myself. So what happens is my pressure goes up or I am having this or that. Saltatory conduction. I know from one of my grandsons that you study, otherwise how shall I know? You study saltatory conduction even from class 7. Am I right? Okay. So tell me, what is saltatory conduction? This is a nerve cell. This is the initial segment. দ্বারা this side also this is the neurilemal seed of the action. This is the action. This is the myelin sheath. Myelin sheath covering the action. Just like this is a myelin sheath covering this part of the, but from here another myelin sheath, from here another myelin sheath. So these are the myelin sheaths, and this is called the node. The distance between one node to another, this is called internode. So this action potential travels from here to here, from here to here, from here to here. So it jumps like this. He's not walking like this, not like this, but he jumps. Who jumps? The action potential. He jumps like this. So it is a very fast movement. So this is called, because of this jumping, it is called saltatory conduction. This is called saltatory conduction. Anyway, I stop here. Thank you very much for your